My name is Kassandra Romas, and this is 30 Medical Minutes. If you've experienced any form of shoulder pain, you have likely heard about rotator cuff injuries and the discomfort and complications they can cause. The joint is a highly complex part of the body that allows the arm to have an incredible range of motion. But this complexity also makes it particularly vulnerable to injury. And when injury occurs due to a lack of mobility in this critical joint, it can be particularly frustrating and uncomfortable. Our guest today is Dr. John Erickson, an orthopedic surgeon who is going to discuss the rotator cuff, its anatomy, injuries, symptoms, and treatments. This is an excellent show about a pretty common problem for many people, and not just those sustaining sports injuries. Dr. Erickson is affiliated with Overlook Medical Center in Summit, New Jersey. So stay tuned for an interesting, relevant show. And now let's welcome Dr. Erickson to 30 Medical Minutes. Thank you so much for joining me today, Dr. Erickson.
Kassandra, thank you for having me. It's a pleasure to be here.
Okay, let's start off by you telling us a little bit about yourself, your background, and your medical expertise.
Sure. So I'm originally from Long Beach, Iowa, New Jersey. There's not that many of us, but we do exist.
Okay.
And so I went to University of Pennsylvania as an undergraduate. From there, I did a year of clinical sleep research before going to medical school at Rutgers Robert Wood Johnson. And I think that actually helped stay with me and make me interested in research, going forward. I stayed at Rutgers Robert Wood for my orthopedic surgery residency, and then attended NYU's Hospital for Joint Diseases for my hand and upper extremity fellowship. Because I wanted to gain additional expertise in shoulder and elbow treatment, I actually pursued some additional training abroad and spent 4 months with some renowned experts in France, and then went to New Zealand for 6 months for shoulder and elbow.
Wow, that's great. And you practice in the local area?
That's correct, yeah. My office is in New Providence.
Wonderful. Okay, well, you have quite an amazing educational background, and you specialize in orthopedic surgery, and our topic today is the rotator cuff. So why don't you start off by telling us what is the rotator cuff and where can you find it?
Sure. So I'll illustrate over here on this picture we've got, but the rotator cuff is a group of muscles that constrains the shoulder joint. And so you can see that they sort of come over here. They are deep to the deltoid muscle. They're really important for keeping your shoulder, as you mentioned, there's tons of movement there. You want to keep it constrained in one place. It doesn't have the natural stability of a hip joint, which is really a ball and socket, as this is much more shallow.
Oh, interesting.
Yeah. So these are really important for initiating movement, because, as you mentioned before as well, positioning your hand in space, all of the movement in the upper extremity really kind of begins at the shoulder.
Okay, so what components, I see this shoulder there, but what is in there? What sort of muscles, tendons,
right.
What do
so
I see?
There are 4 key muscles and tendons that then envelop the shoulder. And so this is the subscapularis muscle here, okay? The supraspinatus muscle is up here, and then there's sort of 2 behind that you can't see in this picture. Mm-hmm. There's also sort of a ball of tissue up there called a bursa. It's like a fluid-filled sac, and that can also become inflamed.
Oh, I've heard of people with bursitis. Is that what that is?
Yeah, it's sort of on a continuum of rotator cuff injury, where we look at sort of the anatomy, but everything in that area can become irritated. So the least severe or the most minor of these type of impingement issues are bursitis, then tendinitis, which can then progress to rotator cuff tears, and then eventually arthritic change if it's not treated.
Okay, so you're saying there's a progression of problems related to the shoulder joint. And you mentioned bursitis first, but then tendinitis. Then does that lead to a tear, or is tendinitis pulling away from it called a tear? How do you describe that?
It is a bit complicated. I think that if untreated, tendon irritation or tendinitis can result in tearing. There are, however, other reasons for tears, such as acute injuries. There's a degenerative process that's happening in many shoulders as they age, where tendon quality becomes more poor and the tendon atrophies a bit. So with a little bit less wear and tear at that point, it can start to tear. You don't necessarily have to have tendon irritation to have a rotator cuff tear, although they often go together, but it's not mandatory. I hope that makes some sense.
So if I hear you correctly, Dr. Erickson, you're saying to me that some of the causes of rotator cuff injuries or discomfort can be age. Is that one of the risk factors?
Definitely, yeah. It's a risk factor not
Oh
only.
dear, I'm in trouble.
So, well, don't lose too much sleep over it, because
Okay.
I think that if you don't have a problem, it's fine. In fact,
Okay.
many people, it is much more predominant as we age. So 50% of people who are 80 and older will have a full thickness rotator cuff tear. However, not all of them will be symptomatic. So as we're more active and younger, a full thickness cuff tear tends to make more of an impact in your life. As your function declines, you may not have the same impact. So some tears can even be asymptomatic. But age is definitely a factor that predisposes us to having tendon quality that's not quite as good, and definitely predisposes you to developing a rotator cuff tear.
Let me go into that a few more seconds, Doctor. When you say wear and tear, are you saying that the muscle is getting weaker, that we are losing our flexibility, or is that degradation of the muscle and tendons? What are you describing here?
Yeah, so what I mean by that is basically other risk factors. So we mentioned age, things that some studies have shown, such as if it's your dominant arm, if you're engaged in manual labor for a long period of time, those are things that can also predispose you to a tear.
Of manual labor, such as, give me an example.
So if you are a bricklayer, if you are a carpenter, if you do work that involves sort of heavier lifting or using of your arms, if you have to lift pipes or other things like that, all these things can predispose you. Again, we're not talking about, it's not a slam dunk for any of these. Just doing that job doesn't mean you'll have a rotator cuff tear. But if you start to combine a number of these factors, we're painting a picture of who is at risk for the issues that can start at irritation of the tendon or result in a tear.
So you can say it can be from your employment or the type of job you do as wear and tear.
Yeah, when I say wear and tear, I'm talking about sort of the combination of a little bit of the natural history of what happens to your tendon, and then how do you actually engage that in the world? What are you doing with the arm?
Okay, good. And you were talking about age, you're talking about wear and tear, and we're talking about people who have a job, and then of course there's injuries. There's the sports injuries, the car accident, and being in the subway. Your arm is up, you're holding on, and the car stops, and you yanked. Can that cause an injury?
Definitely. And those are some of the ones that we want to treat very acutely. So I sort of separate these tears, and not just me, as the orthopedic community in general, into the acute or traumatic tears, and then the ones that are a bit more chronic that happen sort of with the overall, what we said, wear and tear and tendon sort of degradation.
Is there, excuse me for interrupting, is there any family history involved in this? Does it run in families? We know that certain conditions do, whether you have, let's say, heart disease or breast cancer, unfortunately. But something as simple as there is some indication that that's the case. We have not really nailed down any very specific genetic component to it, but the way that your body makes collagen, which is a very abundant protein. It's in bones, it's in tendons, it's in tons of the different tissues you have in your body. That is determined by your genetics, and some people, I think, have collagen that's probably not quite as good, so it does affect rotator cuff, the possibility of tearing, and certainly can affect the ability to heal the rotator cuff. So there is a genetic component, which would be related to the family history, but it's not really fully illuminated yet by the field. Okay, one more sidebar to this, Dr. Erickson. You were talking about age, and many women who are aging have osteoporosis, which we know is a deterioration of the bone. Does that affect it also?
That can affect what we do surgically. So should a patient be required to have surgery, it might affect my approach or the type of instruments I would use. So it's definitely something we are considering for sure. But in terms of actually the rotator cuff tear itself, I would say probably not.
Probably not. Okay, so when should somebody go and seek help, go to a doctor? You have this weakness in your arm, or it's just killing you, you can't raise it, you can only take it this far and not that far. When should we go and talk to you? come and see you?
And I think it's a very, very good question. I think many people have a pain that's very mild, or sort of, I describe it as more of a nuisance than a disability. And if it's a newer onset problem for only a few weeks and it seems more like a nuisance, that's probably something that's appropriate to see your family practitioner about. If you have an acute injury that results in weakness, that's something that we definitely want to look at early. Or if you notice pain that's more severe, pain that's been going on for a longer period of time, or pain that's really interfering with your function, where you can't seem to do some of the things you were able to do before, I would advise you to see a specialist.
Okay, so let's go into this a little bit more. If you're lying down and this is aching you and you can't sleep well and you're taking some aspirin or something like that, and it continues over a period of time, then I should go see you, not to hesitate.
I would say, yes, come and see me at that point, because night pain is definitely one of those things we look at in terms of rotator cuff tears. So if you are really losing sleep, that's one of the indications that you may have a full thickness rotator cuff tear and should, again, probably be seen by someone who deals with the shoulder.
Well, I'm going to tell you, honestly, a lot of people are going to hesitate to contact you thinking that, oh, well, I should just bear with it. I mean, I don't want to bother you and everything, but you're going to tell me, I'm sure, when we talk about treatments, that you can help us. You can make it better so that we don't have to have this discomfort, lack of sleep, lack of flexibility, lack of functionality. Is that correct?
I certainly hope so, yeah.
Am I doing a great advertisement for you?
Yeah, you are. So I really think that most of what you said is true, and there's a wide variety of things that we do. Most people are treated non-operatively. So whether that's a combination of physical therapy, an occasional injection of a steroid to sort of calm things down so people can participate more in physical therapy should they need it. It's only when, I think, it sort of becomes a bit more serious do we need to start talking about surgical options. So if any people are sort of worried that if they walk in the door that immediately a surgeon is going to tell them you need surgery, that's not always the case.
Okay, so to repeat what the symptoms are that cause a person to come and refer to a physician, what would those symptoms be?
The main one is pain. Oftentimes that pain is sort of aching, can be deep, or can also seem like it's in the front of the shoulder. I think that the ones that I get very concerned about are people who notice a significant change in their strength. So if they were able to lift their arm normally, and especially after an injury or something like that, if they can no longer do that, that's someone we want to see more quickly. We mentioned the night pain as well. That's one of those things that is an indicator that if you really can't sleep, you can't put any weight on that side at night, probably should have someone take a look at you.
I'm going to go back to causes, doctor. We've talked about wear and tear and age and even family history. Are there any external factors besides sports injuries and a car accident and everything like that that can cause, let's say, the tendon to weaken or anything like that, or the muscles to weaken?
So one of the things we know for sure after surgery that for rotator cuff repair, smoking plays a huge role. Smoking plays a huge role if you want to have the cuff heal after surgery. However, in terms of causing it, it's a little more controversial. There is some data to tell us that smoking probably plays a role in people having rotator cuff tears, period. So it is likely it plays a role. And diabetes may play a role as well. We see we see probably a slightly increased predisposition to rotator cuff tear in diabetics, and definitely we see problems, more difficulties in their repairs in the diabetic population. And both of those is because it tends to affect the blood flow to the area. So for any type of healing, you're going to need adequate oxygenated blood to really flow to an area and make sure that you can get the bone and tendon to sort of heal back together again.
Okay, so in that case, it doesn't seem like they're related, but everything is related organically, correct? And so if a person has this definite weakness and they cannot have their functionality, and it really is bothering them, but they also have diabetes, who do they go to first? Do they try to treat their diabetes, keep it under control? Or when you see a patient who's coming in with this weakness, are you are you going to follow up with their physician about their diabetes and to make it sure it's under control?
So sure, what we do is first we look at all the patients individually, and one of the things I hope is a huge takeaway here is we're not treating an X-ray or an MRI, we're treating a patient. So depending on what that patient's symptoms are and how severe they are, it will sort of dictate the conversation regardless of their medical comorbidities. And then we start to look at things like, are they diabetic? How well is that controlled? It doesn't necessarily preclude someone from either an injection or surgery or any of those things, but it helps me guide the conversation. So if I could say, hey, we might be able to wait on this, and if your diabetes was a bit more controlled, it might help improve our outcomes, that would be helpful. In some cases where we have to intervene a little more quickly, it just helps me guide the patient and say, listen, there are some risk factors we can't really eliminate. I still think it's worth doing an intervention of some kind, but it's just something you need to be aware of. So I think it just helps you be very upfront with your patient about what your expectations are and what their expectations are.
Okay, well, that's very good to hear that you're treating the patient as an individual and taking into account their entire medical history. And that guides you into determining what sort of action you're going to take and what sort of how your diagnosis goes for treatment. So, yeah,
definitely. I mean, look, if you're not looking at the patient on the whole, then I think your outcomes won't be as good. And these aren't just outcomes we're talking about. It's just, someone's functionality. It's their life.
Yeah, this is their life and comfort. So let's get on to treatments then. So let's start when somebody has a soft weakness. It's not causing them where they can't work or they can't function. So how do you treat them? What do you recommend first?
So for people that don't have a significant amount of true weakness in their arm, they have pain, it's been nagging them for a while, based on some physical exam maneuvers, we can sort of indicate that, we call them impingement maneuvers. We look at sort of this, I'm going to head back to this picture
please.
here. Underneath this bone here, this is called the acromion, it can make an impact on the rotator cuff and on this area, the bursa as well. And so if I'm examining you and I feel like certain moves that I do on your arm or certain physical exam things that we will do in the office are causing you pain, that's when we start discussing, are you amenable to an injection of steroid into this area, and should we consider a course of physical therapy to try and strengthen the other rotator cuff muscles and help keep the shoulder balanced and sort of healthy in the place that it's meant to sort of reside. If that's no longer working...
Okay, let's stop for a second. Did you say steroids?
Yes, so a corticosteroid is an anti-inflammatory injection.
Okay, so with the anti-inflammatory, what you're doing is that you're reducing the inflammation, obviously, in the tendon.
Yes, so...
But not the muscle.
Right, so most of what we're actually looking at is the tendon.
The tendon.
Where you become, where most people have pain is the tendon itself.
Okay.
The muscle's a bit farther back. It's critical as well. Obviously, if you don't have a muscle that is shortening, you can't pull the shoulder anywhere it needs to be. But the key part that we're talking about mostly revolves around the tendon and how the tendon inserts on the bone.
Okay, good. So you're talking about, number one, your non-surgical treatment would be a steroid injection and some physical therapy.
Typically. Although sometimes people that have very mild irritation can be treated by anti-inflammatory oral medications.
Okay, does that mean that you could take a Tylenol or any one of those over-the-counter medicines?
Sure. I mean, I think Tylenol doesn't actually have an anti-inflammatory component
they
exactly.
mentioned the right one.
But yeah, so I would say Aleve is one of the ones that we use a lot.
Okay.
If people have the ability to tolerate it in their stomach. Sometimes people have some issues tolerating some of those medicines. So it's one of the things we'll talk about in the office.
Okay, great. So you're starting off with over-the-counter medicine. You're starting off with an injection of anti-inflammatory steroid, and that can give a person some immediate relief. And can it last a long time, or do they have to repeat this?
So it can last a long time. For people that get some benefit, but it doesn't last despite their best efforts at non-operative management, that's when we start looking at how much it's impacting their life and should we explore surgical options.
Okay, so talk to me about that.
So generally what we'll do is sort of an investigation of what does the tear look like, how healthy are the tendons themselves. So many people will get an MRI at this point if they're considering a surgical intervention. That helps guide us to say, well, this is what the tear looks like. this is what the quality of the muscles are around the tendon, and should we pursue a repair. And that repair can be done through a small open incision or using a camera called an arthroscopic surgery.
Okay. Now, I could see a young person who's had, let's say, a sports injury, a car accident, or an accident on their job, coming to you and saying, "I got to fix this right away. You got to take care of this. I can't work. I can't play. I can't do anything." Would you guide them? You said you don't follow an MRI, but you follow a person's individual life story.
Right.
What would you do in that case?
So I think in a patient who is young and relatively young, I mean, certainly we're looking at sort of under 60, as people that are still doing a manual labor type of job. If they really can't work, that's an important thing to sort of address early on, because they frequently need work to live, right?
Yeah, of course.
So that's part of the holistic, I guess, looking at a patient, right? So I think those are people that we're taking into account all of those things. Inevitably, for people that do manual labor, you will have to be off of work for some time. Just because we put some anchors in the bone and fix the tendon back down to where it goes, that's a temporary measure. Your body has to actually heal, and we're just holding it in place while your body sort of forms the appropriate tissue to keep the tendon back in its original location. And so if you were to return to activity immediately, whether that's manual labor or really just lots of different activities you do around your house, that could be problematic. So we encourage people to stay in a sling for 6 weeks usually, and then from 6 to 12 weeks we have them work with therapists a bit more.
Okay, so what do you actually do to repair a tear? So tell me about your surgical procedure. What do you do?
I'm going to actually click over just 2 pictures over here. So this is an illustration that shows, this is the humeral head right here. This is that part of the shoulder that is attached to the rest of your arm. And this is one of the rotator cuff tendons coming down here.
Okay.
And this illustration shows these metal things, which they don't always have to be metal, they could be different types of plastic as well, that are inserted in the bone called anchors. And these are sutures that are attached to the anchors. So naturally what happens is that the muscle would be pulling the tendon back after it tears. We use these anchors to tie it back down in place and hold it there while essentially a form of scar tissue forms to really anchor it back down there again.
Oh, okay. So you've pulled the tendon and attached it back to the actual bone. That's
Yes,
the bone.
That's correct. So most of what we do, and it's not true for every single surgery, but in orthopedic surgery in general, and certainly in upper extremity surgery, restoring the anatomy is mostly what we do. So what we try and do, if at all possible, is restore the natural anatomy. And so what we've done is we've taken this rotator cuff was torn, it was up here, and we've now moved it back down to its anatomic location on the greater tuberosity, and we anchor it in place so that it can stay there.
Okay, and then the natural healing process is that cells regenerate, and they're going to help grow and reinforce the attachment.
That's correct. So basically, some bleeding that occurs either from the bone and some of the blood flow into the tendon itself help form a type of scar tissue that's very strong. It's not quite as strong as what you had before, but it's still quite strong. And luckily, it can continue to regenerate. So small stresses on that will be okay. But yeah, eventually any material that's not biologic, so those sutures, they would fatigue and break. But if your body heals it in place, that becomes a sort of fancy jewelry that just stays there. There's nothing, it doesn't do anything anymore other than the initial thing it did.
So what you said is that there's a natural healing process that a person will be in a sling for 8 to 10 weeks, or
Generally a sling for about 6 weeks.
6 weeks?
There is some, there may be some therapy that happens before that, but for the most part, for the first 6 weeks,
it remains immobile.
People remain immobile, predominantly. From week 6 to 12, we work more with a therapist and more with restoring something called active assisted range of motion, where people aren't just lifting their arm right away, but they're using their other arm to sort of help guide that arm and start to engage the muscles there.
You just brought up a very interesting point. If this arm, let's say, this arm is immobilized, and you have to use this arm, are you putting this arm and shoulder in jeopardy?
So I don't think we can answer that 100% with 100% accuracy. No, it's a good question, and I actually hear that type of thing a lot. What we do notice is that sometimes people will have they'll be in a sling for a bit, and they'll sort of cheat with other parts of their body to lift things up, and they will get some soreness in other parts of their neck or back. That tends to resolve once they're able to sort of restore their posture, they're no longer wearing a sling, they're able to sort of use their other arm a bit more. So it tends to resolve. Could using one arm more exacerbate some underlying thing that's already been there? It's certainly possible, but we don't have a lot of other options available to us.
So getting back to it, physical therapy is basically exercise. So you're saying that one of the preventions of having this would be to have a regular form of exercise where you strengthen the muscles on your shoulder, your back, your neck, everything, right? So
I think that would definitely be helpful. There's not a lot of really strong evidence to provide us with an exact number of how much you're reducing your risk in terms of preventing rotator cuff tears. But we do know that it's helpful, and it helps sort of maintain the overall quality and strength of the rotator cuff tendons. So it's one of the mainstays of our treatment for physical therapy. So if you find that you have someone who doesn't have, let's say, a massive rotator cuff tear, but does have some irritation of the tendons, and we want to sort of prevent that, once they're able to get that under control, we do encourage them to continue those exercises, because I think that helps maintain normal movement of the shoulder.
And that's just healthier anyway for the
Absolutely.
general thing. Are there any side effects of your surgical procedure at all? And if they are they just minor and temporary?
So in terms of surgery, there's risks that go into any surgery, and it sort of varies based on the type of surgery you're doing. Rotator cuff surgery has very low risks. Most of the risks involved in the surgeries that we do are actually involved with the anesthetic, depending on what your health comorbidities are like. Risks of blood loss are very low. Risks of infection exist, but they're very, very low. Things that we are concerned about is that we want it to heal, so it's a job that we work on with the patients, and we want them to get their mobility back. And so that means that if you did nothing for a long time, you would have a stiff shoulder, and so we have to have you work usually with a therapist and work at home to make sure that you will restore that range of motion.
Okay, fine. So then I'm hearing that it's actually a pretty safe procedure, that a person should not hesitate to consider it if they're totally in such pain and discomfort or not functioning properly, correct?
Correct. I think that any surgical discussion revolves around sort of what is the current quality of your life, and then I can sort of guide you in the risk-benefit analysis of, what are the risks that you would face in any surgery, and is it worth it? So if it's a small nuisance in your life, I generally would say, this is not, surgery is not a good discussion for you. As we get sort of in that spectrum closer towards, this is really disabling me, or this is really impacting an important part of my life, then we start having a discussion that's a bit more in line with surgical management.
And as you said earlier, you're treating not the MRI, but you're treating the patient.
Correct.
And so we thank you so much. And we thank you for joining us today on 30 Medical Minutes and learning all about the rotator cuff and treatment that Dr. Erickson and his colleagues can provide. Thank you.